can say.
Hi, everybody, and welcome to our May webinar for GaPQC's Optimizing Newborn Nutrition. Thank you all for joining us today. We have a great data update and educational webinar prepared. But first, I want to go through a couple of updates. Quarterly reports have been posted on Teams. Those reflect your July 22 through March 23 data. If you have submitted a SMART aim and you don't see it reflected on your report, you can email Linda Pham. Her email address is listed there, and she'll be able to add it to your report. Just email her, go ahead and send her the SMART aim that you submitted, and she'll make sure that that's added onto the template, so it'll be reflected on reports moving forward. And if you're not muted, can you make sure you mute yourself so we just don't have that background noise. Thank you. We have an update on microlessons. We're really excited that we have been posting some new microlessons and have a few that will be uploaded in the next couple of weeks. So you'll notice here that the ones that are bolded are available now, and it shows where they're paired with the topic from a previous month's webinar. So the November webinar, for example, is keeping mothers and babies together. There's a new related microlesson that's on breastfeeding and NAS nows. So if you haven't seen the webinar, you can always go back and view that posted on the GaPQC website. And if you did attend those or you have seen the recording, please go and see the microlessons, take the microlessons that are available on Train. So again, if they're bolded, that means they're up now, ready for you to take, and if they have the asterisk that they'll be available in the next couple of weeks. You'll also notice if you go to the GaPQC website where the webinars are listed, that there's now a link to record your attendance. So if you saw the webinar live, you don't need to do anything. We have you recorded as being on there live. If you saw the recording after it's posted, please go back, use that link that's next to that month's webinar and record your attendance for that webinar. Or if you're going back and you're viewing it for the first time, use that link after you viewed the webinar to record your participation and your viewing of that webinar. A great way for us to keep track of the reach of all of the learning that we are providing through the initiative. And we'll let you know when these next microlessons have been posted. The Emory Conference on Breastfeeding was a great success, and all of the sessions were recorded and are available along with 10.5 hours of continuing education for doctors, nurses, dietitians, and lactation consultants. They're on demand and they're available through May 30th. There are about 30 more on-demand registrations that are supported and sponsored through GaPQC for participating members of GaPQC to access those on-demand sessions. We will put the link in the chat for registering for those. There is a code that's 2023 BF space GaPQC. We'll put that also. We'll make sure this is in the follow-up email as well. So make sure if you've already gotten your access to those on-demand sessions, you have until May 30th to go and view them. And if you are just now taking advantage of one of those spots that's available using that code, make sure that you do that before May 30th when that access ends. And on May 16th at 9:30 Eastern Time, the WHO will publish 2 important new policy and programmatic resources on kangaroo mother care, a global position paper and implementation strategy for health policymakers and program managers, following the release of landmark new guidelines for the care of preterm or low birth weight infants in 2022. These guidelines recommend kangaroo mother care as the essential standard of care starting immediately after birth for all babies born early, so before 37 weeks of pregnancy, or small, under 2.5 kilos or 5.5 pounds at birth. We invite you to register for the webinar to discuss these resources, hear from key stakeholders in newborn health about their plans to support implementation and scale up of kangaroo mother care for all preterm or low birth weight babies. We'll make sure that link for registration, you see it here on the slide, along with the details of that webinar, that will be in the chat along with in the follow-up email so that you have that information. And now I'm going to turn it over to Dr. Patel for a data update.
All right. Can you see my screen, Kimberly?
Yes.
All right. Well, good afternoon, everyone. I wanted to share the data. Our goal is to give you quarterly updates. And so this was something that you might have seen for those of you that were at our annual meeting last month, but I thought it'd be a good time to just share and give you a brief update on how we're doing as a collaborative as a whole with optimizing newborn nutrition. As a reminder, our goal overall within the GaPQC is to increase the percent of newborns in our hospitals with human milk as a first feeding from our baseline of 73% to 80% by September of next year. So every 3 months, we collect our data, and this is how we've been doing. You can see our performance from when we began our audits in July of last year, and where we're at, and as here's the dotted line. Now, this is how we do based on all of the audits you're doing, where every hospital is weighed equally. And we really do encourage you, this is our data through March, for each of you to take these reports and share this with key stakeholders in your hospitals to share how you're doing and where there might be opportunities with the measures. This is, of course, our primary measure for overall collaborative, where we're trying to move the needle on this to get above 80%. But for your individual hospitals, you may be choosing other measures. And so one of the secondary measures we have here is formula supplementation of last week. And here we're one of the aims we're looking for is to see if we can decrease the amount of formula supplementation, which has been around half babies in our GaPQC hospitals are receiving formula at some point in the prior week during your audits. And this is both in the neonatal intensive care setting as well as in the well newborn setting. And then finally, the last measure is breastfeeding expression within 6 hours. And you can see this is about 50% of audited infants. And we have seen here, looking at kind of our baseline, several months, actually 6 months above this baseline measurement period, where we've seen potentially some improvement. We're going to keep track of this. And this is the third measure of the 3 key measures that we have for our initiative. So these are every 3 months. My goal is to give you an update and let you know how we're doing as a collaborative. And as these reports come to your hospitals, we hope that you take a look at this, share this with your team, use this really as data. We want to do this measurement, not just for the sake of measuring, but actually to give you an idea of how you're performing and to really use this to guide improvement and to guide testing and change. One of the things we did in our last audit in January was we reassessed kind of some of our structure measures and how we're doing with various policies related to newborn nutrition. You can see we really had some nice movement on some of these policies. Thank you to all the hospitals that responded. This will be done again in the summer and then again next year. And what we hope is over the course of this period of time that we'll see more darker greens, which indicate that most of the hospitals are now having key policies related to these different aspects that are essential to newborn care and nutrition. And as always, we know that this is work that you all are doing for these audits that are done every month, and quality improvement without data is really not quality improvement. You need to know whether changes you're making in your local settings are resulting in improvement. For that, we really do rely on you for giving us this information. So thank you to all the hospitals for completing these audits. We've really been very happy and grateful to see the engagement in doing this. We know we try to make this as simple as possible, but we realize this is really critical for us as a whole state within the GaPQC to know how we're doing, but also for your hospitals to know how you're doing. And one of the things that we really are going to put a bigger focus on, particularly for the second half of this year, and as you listen to these webinars, as you do these micro lessons, start thinking about interventions and changes. The current system that you have in your hospitals are designed to get exactly the performance you're achieving. And so if you want to improve on that, I think it requires thinking about changes and testing. And there are a number of different interventions or goals in these webinars to give you ideas for change that are related to the outcomes you're focused on. And we hope and we know, and we've been grateful to see some of the key driver diagrams that you've sent to us. And one of the things we really want to work on over the next half of the year is start thinking about actually addressing some of these interventions. And so as you listen to these webinars, as you listen to our experts, think about how you might apply some of this to the care in your hospitals. And with that, I'd like to again thank the neonatal community, and I'll stop there.
Thank you, Dr. Patel. Now I'd like to hand it over to Claire Eden with Georgia AAP to talk about our educational section.
Yeah, hi everyone. I want to make sure that my partner in crime is able to be on camera and mic too. Teresa, are you here? And can we hear you? There she is.
Can you hear me?
Yes, great.
Right,
Welcome.
great.
So,
Thanks,
really excited about our webinar today on responsive feeding, reading the cues. I want to first give some credit to Dr. Taryn Fairley for preparing many of today's slides and introduce my friend and colleague, Teresa McCullen. Teresa works as a lactation consultant and has for many years at what has been known by many names, but we think of as MCG at Augusta University. She supports both healthy term babies, NICU families, and mothers of infants and children admitted to the pediatric hospital there. She's a leader in the lactation field. She, of course, you saw her name on the last slide, serves on the GaPQC Neonatal Advisory Committee. She's also currently the vice president of the Georgia Breastfeeding Coalition, a board member of the National Lactation Consultant Alliance, and of course, is past board member of her, and I think president of the local coalition there in the Central Savannah River area. She served on several other perinatal organizations, such as the Southeast Lactation Consultants Association. If you can go to the next slide, please, Kimberly. Excited about getting to this place in the initiative, talking about responsive feeding is such a critical part of optimizing newborn nutrition, which is our whole purpose in gathering every month. So we're going to talk about responsive feeding both in breastfeeding and bottle feeding patients. And first, I'm going to kind of set this up by asking us to consider what is responsive feeding, and really at the heart of it is recognizing, acknowledging, or maybe even honoring that the newborn infant is and should be an active participant in feeding. So simply put, it's using the infant's cues to inform our role in initiating and stopping feedings. And it's also known as feeding on demand or cue-based feeding or infant-directed feeding. And I am going to pass it to Teresa then to begin to illuminate why implementing and teaching responsive feeding is so critical. Teresa.
Thanks, Claire. Being held and fed almost continuously in early infancy is hardwired into the lactation physiology and the infant nervous system. I find myself reminding families of the fact that babies have skills to breastfeed and they are participants in feeding. And you'll hear us address that issue later on in the talk. We are carry animals, just like marsupials and apes, and infant survival depends on being held and fed almost continuously from early infancy. We know these are important characteristics of newborns, and without that constant touch, children can develop reactive attachment disorder. Therefore, we know babies need to be held, loved, and fed constantly in their early months of life. Non-responsive feeding has implications for pediatric obesity. Studies show us that parent-directed feeding, non-responsive feeding, restrictive or permissive, is associated with increased risk for overweight, obesity, while infant-directed feedings provide an isocaloric feed that fulfills the infant's needs precisely. Next slide. We have some caveats about who to listen to. So but when babies are allowed to direct feedings, we need a baby that's trustworthy. Never trust a preemie. Babies need to be on the trajectory for normal weight gain. And the newborn infant weight tool from Pennsylvania is helpful in getting that information, as well as growth charts. And the baby should have no significant medical issues, such as Down syndrome. Next slide. So what is the role of responsive feeding in appropriate weight recovery and gain? Responsive feeding in healthy infants is an important element of appropriate weight recovery and then gain. For example, when cues are suppressed with swaddling, pacifiers, additional feedings that the baby needs to have can be suppressed and milk production reduced. Next slide. When we don't use responsive feeding, physiologic volumes, and pace feeding techniques, many babies are overfed, which results in delaying the next feeding, which amounts to fewer feeds in the long run and suppression of subsequent feeding cues. Let's think about what message it sends to parents when the newborn's crib is stocked with unlimited 6-packs of ready-to-feed formula in 2-ounce volumes. It sort of gives parents the impression that we think that their baby should be fed 2 ounces. When supplemental feeds are indicated or desired, if they occur without the accompanying breast stimulation and removal of milk via the hand expression or using a breast pump, this is what an economist would call opportunity costs. Supplementing with formula without also putting in the orders these methods I just mentioned will inevitably interfere with the mother's milk supply. I encourage everyone to check out our previous webinars on golden opportunities for the golden hour and keeping mothers and babies together for more on the topic of rooming in and skin-to-skin care. May this month is Kangaroo Care Month. I think that's an important step in helping families and all caregivers understand the importance of that for infants. We will review these particularly today, skin-to-skin and kangaroo care. When we teach families to feed every 3 hours, or we encourage pumping schedules that are Q3 hours, both nurses and staff and parents think it's important to only feed or only pump on this 3-hour schedule. And that is somehow, it's valuable to wait 3 hours before you begin to feed the infant or pump in spite of cues. We want to think about teaching physiologic volumes and consider what providing those 6-packs of ready-to-feed formula do to this concept and getting this information across to families. We will be having a webinar on physiologic volumes and appropriate supplementation. Teach pace bottle feeding so sucking needs match up to the caloric needs of the infant. There is a micro lesson being prepared on teaching pace bottle feeding coming up. How can hospitals teach responsive feeding? The baby is the very best tool you have. Claire and I were talking earlier about the fact that even if the baby's not awake, using the baby to help the families just watching the baby, looking for cues, or if you're doing positioning, the baby can be your number one help. using printed handouts, posters on the walls, and or teaching, it's just not as effective when you're when you can use the one thing that new parents are compelled to want to pay attention to, and that's their baby. I think I can speak for most of us when I say we were sad that visitors are now back after a few years of pandemic-related visitor limits, but because we know visitors can interfere with feeding and recognizing feeding cues, but we can turn that to an advantage by showing the visitors what the cues look like and teaching the visitors along with the parents how pacifiers and swaddling can suppress feeding cues. And this is important because oftentimes the visitors are going to be part of the support system for the families once they get home. So that can be most helpful. How can hospitals teach, again, a second part on how hospitals can teach responsive feeding. One thing we often miss when teaching about feeding cues is that we should watch for signs to end a feeding, not just begin one. Left to our own devices, if we handed our newborn, we're handed our newborn and a bottle of milk with the standard flow nipple, we just cradle the infant on their back and introduce the bottle to the infant. The infant is compelled to suck and will soon begin guzzling the milk. New parents and even healthcare providers interpret this as the baby being really hungry, especially if there's a lack of confidence surrounding breastfeeding. When in reality, it's just an inexperienced baby trying to learn how to manage the flow of milk. And we're all familiar with belly balls and posters about stomach size. And you might ask, well, what about those? The debate over stomach capacity is basically moot in this discussion. Humans by nature vary their intake and will not eat to capacity with every feed. This is why if a baby is bottle fed, paced feeding is very important. The usual recommendation is 2.5 ounces per pound of body weight per day. This is easier to work with when than saying a baby needs 2 ounces every 3 hours. To shift gears a little bit to the foundational paradigm that we're trying to encourage you to make today, and that is to truly center breastfeeding as the biological norm. First, as with the belly balls and stomach capacity posters, humans like you and I don't always eat the same amount of calories at perfectly spaced intervals. It is healthy to listen to our bodies, and studies show we do a good job from infancy of moderating our intake to meet our needs when we are given the opportunity. Secondly, human infants are not designed to be passive recipients of feeding. Even referring to it as feeding makes it sound passive. I'm going to feed you. Instead, consider newborns as active actors or participants in the learning to eat process, and we and their parents are their teachers. For this reason, we should resist the need to measure and standardize volumes when it's not medically necessary. We spoke earlier this year about lactation risk categories, and we'll be coming back to that this fall. We can use the level of risk to help guide how much we need to monitor frequency of feeds and volume of feedings. So if we are to allow the infant to guide the initiation of feeding, we need to learn to listen to them. Even though they can't speak, they are communicating with us. Let's take a look at everybody, I'm sure, is familiar with early, mid, and late cues. We'll take a minute just to review them. And this is something that parents, when they become familiar with this, their comfort level increases. The early cues include staring. Sometimes their eyes are closed, but their eyelids are moving. That REM sleep is apparent. They're opening their mouths. They're turning their head, and that message is I'm hungry. So if we move to the mid cues, there's a little bit more physical activity, stretching. A baby may put their hand to their mouth, and this message is I'm really hungry. When the baby shifts to the late cues, crying, extreme agitation, turning red or turning colors, generally means I'm really upset. So we've moved past I'm hungry to I'm upset because my cues about hunger did not get answered. So this is helpful information for parents to be able to use and feel successful about. So what happens when we listen to the baby? The fact of the matter is babies do better when they get to call the shots. Infants feed on demand, who are fed on demand, we know gain more per day than those on a schedule and have an increased percent of fat with more frequent feeds. Responding to infant cues is the key for success in any breastfeeding journey. Learning to breastfeed may make infants less efficient or need more help, and so therefore more frequent feeds. The old adage, practice makes perfect, applies here. Some infants need more on-the-job training at the breast to learn. Limiting feedings limits weight gain and interferes with the milk transfer and milk production. Some babies are not very efficient, so need more practice, as I mentioned before, and time to submit the behaviors that are associated with successful feeding. Again, if safe, if weight's not an issue and the baby is a reliable reporter, then optimal feed should be on cue.
Teresa, can I jump in for a second on that
Yes, please
topic? I was thinking, we had been discussing this, but I was thinking about what it means when a term baby is sent, a pretty healthy baby, but that may have some minor issue that needs observation for some period of time in the NICU, right? Like in the first 12 or 24 hours, that how much, there's medically necessary reasons to do that. But what we miss there are all those opportunities for the baby to learn to breastfeed and to stimulate milk supply. So we have to kind of mitigate that by, trying to get the mom to the NICU or the baby to the mom for feeding when we can, and making sure that the mother is hand expressing and that we have a system in our facility to kind of ferry that hand expressed colostrum to the NICU to kind of to try to replicate that even when mothers and babies do have to be apart. But then also like whatever we can do to avoid kids ending up, term babies in the NICU, because we know NICU feeding just works on a whole different schedule and system that I know we're going to talk about some more in this webinar. But sometimes we're putting otherwise healthy term kids that need brief observation into that NICU kind of setting, and how it can really derail a lot of opportunities to learn, because they're still going to be discharged pretty soon, right? But we missed like this whole window.
And it sometimes takes a little sleuthing to make sure that in your institution you have a mechanism for mothers can visit their babies, get assistance with putting the baby to the breast, and get assistance with removing their colostrum to supply when they're not in the NICU. Next slide. So we mentioned earlier that responsive feeding is built into the infant's nervous system and into lactation physiology. We've been learning throughout the initiative about how effective milk removal early and often is the key to optimizing milk production. This graphic is a representation of how this is often played out and how it can lead to low milk supply. We start with any concern of milk production or feeding effectiveness, and that leads to supplementation with formula without the accompanying removal of milk or milk expression, and the breast then miss the opportunity to be stimulated, which completes the cycle by literally suppressing lactation, the opposite of what we want. And as we know, the more milk that goes out, the more milk that is made by the breast. So conversely, less milk out means less milk made. There is an important rule. I like this graphic. In breastfeeding, the milk truck arrives no matter what, but babies create and regulate how well it's loaded. I often find myself talking to parents about this fact and they sometimes it's not familiar to them, and so they have a hard time. They don't see the milk pouring out, or they can't turn the spigot on. And so how I often have said, well, when the pregnancy ends, lactation begins. Your pregnancy has ended, your body knows your baby's here, and so the milk is available for the baby. And that sometimes makes them, because they know they're not pregnant. They don't know about the rest of what I said, but they do know that they're not pregnant. The truck arrives, but the baby creates and regulates how well it's loaded. And that's an important piece to remember. Well, what does this mean? Milk production occurs in 3 stages. Lactogenesis 1 occurs in the pregnancy phase, where high levels of progesterone allow for milk to undergo changes and develop the ability, the breasts rather, to undergo changes and develop the ability to secrete milk. Once the placenta is delivered, the progesterone drops while levels of prolactin and cortisol, insulin are elevated. This produces copious amounts of milk for the baby. The final milk supply is all maintained in under autocrine control. So the more that comes out, the more the breast makes. Frequent emptying of the breast and nerve stimulation around the nipple sends messages and signals to the brain to release prolactin and oxytocin, which keeps the cycle of milk production and availability for the baby. So for the supply and demand phase of breastfeeding, the value of milk on board is dependent on how frequently early milk has been removed. Early milk removal, less than 24 hours after delivery, is associated with an 150 cc per day an increase in the amount of milk that's collected in the first 6 weeks of life. The infant is determining the supply, and this is important for all lactation in the early days. And so that's a real important part for us to make sure that we're catching. Studies of pumping mothers of very low birth weight infants have shown that removal in the first days of life resulted in that number that I gave earlier, 150 cc's more per day. And we got to hear that directly in last summer's webinar called Time is Tissue. A very new study reinforces these principles. The study looked at factors that NICU mothers who were successful in coming to volume, which in this study was defined as expressing at least 500.
That should say 500, yeah. Not 5,000.
Not 5,000.
My mistake.
Expressing at least, that's all right, 500 milliliters per day by day 14. And these are some of the things that they had in common. And the two of the things that they had in common were that, and remember, this is for moms whose babies are separated, they are separated from, that they were expressing at least 5, yes, I said 5 times a day by day of life 5, and that at least one of those pumping sessions was between 1 and 5 a.m. I know everybody is raising their hand to say, no, they need to pump every 3 hours, and they need to pump at least 8 times. I know recently, that's the kind of thing that I was saying, and more times for 24 hours, 8 or more. And but when we look at the mothers, we're looking at mothers that we've worked with in the past, myself and Claire included, on day of life 5 or 7, and in Claire's case, she's only meeting them for the first time. I have usually seen them in the hospital, in the postpartum unit, but they really struggle with their milk supply if they have not met these 2 markers. If they are not pumping at least 5 times by day 5, and if they are not waking up to pump at least once at night. So the reason frequent milk removal is important for both the mother and for of healthy term babies and for those who are pumping is a little protein called feedback inhibitor of lactation. It's found, it's a whey protein that's found in breast milk, and it's found in higher amounts in engorged breasts, resulting in negative feedback to the brain, which then results in decreased milk supply. We shouldn't be telling families to wait 3 hours to feed their baby if the baby's queuing sooner. And conversely, we shouldn't having mothers stick to a strict schedule of only pumping every 3 hours. If your hospital has a nursery, one of the functions should be to watch for babies feeding cues and take the mother, her baby, when they're queuing rather than suppressing feeding cues to help the baby make it for the 3 hours. Parents often also misunderstand what every 3 hours means, um, and think it means from the end of the feeding, which can result in underfeeding. The baby's actually going longer than 3 hours, especially when a baby is not 100% trustworthy. The preemie babies and the babies that may have some other situations that prevent them from queuing reliably. Parents should be advised that if we're getting close to the 3 hours from the beginning of the last feeding, the baby should be assisted in waking up. And that means unwrapping them, place skin to skin. I often have to take off socks and gloves and always take off the hat. It helps the babies listen to the messaging that they're getting. And if the baby is still sleepy, it might be a good time to change the diaper. And conversely, if the baby's winding up and quickly progressing to the third stage of queuing, it's okay to initiate feeding and delay the diaper changing. Especially because sometimes diaper changing is a real process with new parents and can take a long time further delaying feeding. It's best to get the baby feeding when the cues are early. And to review briefly, responsive feeding improves infant weight gain and improves milk supply. Pace feeding and proper bottle nipple flow are essential and key. Responsive feeding is important for both breastfeeding and formula feeding families. Normalize frequent feeding, but make sure that you're doing this in a way that is safe for the baby. Prime opportunities are presented for us to teach the signs of satiety and kind of notice how the baby is self-regulating. And learning that early will help families in the long run. Responsive bottle feeding is important for breastfeeding families, but also for formula feeding families. Again, you can point out what the baby looks like when they're cueing satiety. And how that means that they're controlling the amount of milk that they're taking for their needs. Supporting a breastfeeding parent who's separated from their infant means making a plan to reintroduce direct feeds. And that, you know, how in nursing they say that discharge begins at admission. This is that kind of thing. If the baby is going to be separated, we want to put that in the front. How is the baby going to return to feeding at the breast? Don't wait until the baby's crying. And often I in I thought that was an old-fashioned concept, but I do run into it quite frequently from staff members as well as parents. The baby won't feel well, feed well, and also pointing out that gulping can result in overfeeding, which makes the feeding less successful. And helping a tired mother doesn't mean supplementation. This is especially important in the early times in the hospital. Partners can be in charge of changing all the dirty diapers, bringing the baby to mom, recognizing those cues, and bringing the baby to mom, and then putting the baby back in the bassinet or crib after the feeding. Supporting mom's care by getting them a snack or anticipating their need for hydration, and then once you're home, assisting with cooking, laundry, cleaning, and all of those household chores. So speaking of tired parents, what do we do on the second night when the baby's awake and they're queuing constantly, they're hard to settle, and mom is still in the colostral phase of milk production? Keep feeding. I think this is very cute. Babies are tiny cave people. The dark and the quiet makes them feel safe and relaxed, and they feed well in those situations. Feeding a lot at night is biologically driven by the infant's primitive brain. Sleep training of any kind is sure to be an exercise in frustration for any neonate, and any parent that's thinking about using this technique should be encouraged to wait until at least 28 days after birth and when the infant is gaining well and milk supply is well established before even thinking about doing any sleep training. The pathophysiology of lactation is also at play here. There are diurnal patterns in hormone production, like, for instance, during the day, there's more estrogen, while at night, there's more prolactin produced. This is why it's important to get that middle of the night pumping session for NICU babies, and why these moms see a dip in supply when the night feedings are dropped. Early mornings are peak prolactin time, and prolactin is what stimulates milk synthesis. So we should prepare parents for this second night delight. It can be a tough period, and teach them techniques that help them to calm the infant and promote optimal feeding, such as skin to skin and frequent feeding. The baby is putting in the orders for the robust milk supply during lactogenesis too. This is a great opportunity to teach about safe sleep and proximate sleep, as the AAP recommends. We will have a micro lesson soon on this topic as well, but frequent cueing and nighttime feeds with the baby close by on a separate sleep surface are important SIDS education topics. Breastfeeding is protective against SIDS and sudden unexpected infant death. Providing human milk to your infant for at least the first 2 months can decrease the risk of SIDS by 50%, and that's quite significant. So, cue-based feeding in the NICU. What do we need to know here? Let's apply what we've talked about with respect to the NICU thus far. When researching responsive feeding and its application in the NICU, we came across this information from Texas Children's. They succinctly state that what we are looking for is a culture that is infant-driven versus volume-driven, which focuses on the quality of learning to eat rather than the quantity fed, modifying feeding schedules and volumes to respect feeding cues and the individual baby's rhythms. And in addition, focusing feeding progression around the infant's skills rather than the caregiver's skills. Cue-based feeding in the NICU, of course, this can be an entire webinar topic, and we can come back to it if there's demand among our NICU participants. Signs of readiness to feed. So let's look some more at how babies develop these skills. We focus on what we see when the infant is laying on their back. Remember those photos of that I went over with infant cueing, the view that we had of the infant. The babies were almost inevitably on their back, and the view was kind of overhead. But humans, like mammals, feed best in a prone position. And I want you to imagine two scenarios, if you will, for a minute. When infant behaviors, what infant behaviors do we see when we put a baby skin to skin on mom's body versus when we lay them swaddled in her lap and ask her then to put her baby to the breast? We need to get away from a successful feed being defined only by how much or the volume of milk that the infant consumes. We should avoid teaching nurses, parents, and caregivers that they are completely responsible for the volume that the infant consumes and that the infant has no role there. It's not acceptable to use any technique to get the infant to take more volume, regardless of the stress signs displayed. Take a look at these stock photos and look for contact, flexion, and if you can see the baby's hands. Look for how gravity is acting like a third hand for the mother and keeping the baby to her body because she is slightly reclined. Note how the baby is unswaddled. Ideally, the baby and mother are skin to skin, but finding pictures of skin to skin mothers and babies is a tall order when you're looking at stock images. They don't really go for a lot of skin being showed. Now think of how mothers are positioned in your facility and how your team can work to facilitate contact, flexion, and the baby having access to touch the breast with his or her hands. Keep in mind that older babies who are feeding well need much less help and can usually find their way to latch on by getting the breast in their general vicinity, or them in the vicinity of the breast, vice versa.
Can we go back to that? I think we missed a slide on contact flexion and yeah.
Oh, we did. We did miss one.
I mean, I think it's just reinforcement of what
Yeah.
you said, but I just kind of liked breaking it down to those three things.
Right. And so if you remember, I mentioned earlier in the webinar that the infant should be and is an active participant. We want them to have access not only to all their senses, such as sight and smell, taste and touch, but also positional stability. And that's kind of the thought behind taking off hats and extra clothes and definitely socks and gloves. Stimulating those senses and positional stability are both achieved by maximizing contact between the ventral surface of mother and baby, shifting weight so gravity is holding baby onto the mom with her leaning back and encouraging biologic flexion. Biologic flexion, arms and legs towards chest with midline orientation, which can be promoted by skin to skin positioning. Contact, flexion, and hands on either side of the breast are ideal positioning to elicit those feeding behaviors and cues we're teaching parents to look for. They have the added benefit of making the mother more comfortable also. A comfortable mother.
I've just seen the physical stress like just drop out of people's shoulders when we get them more reclining rather than hunched over. And I'll never forget the first time I helped a baby who had was paralyzed really from the hips down, his baby was spina bifida, when I was, otherwise totally normal and healthy and raring to go. And I was kind of helping this. It was a first time mom put the baby to breast, and it just made me realize how much babies who have full use of their legs and hips use their lower body to position themselves at flexion and the roll. Like you don't really notice it until it's absent. And it really reinforced to me, we can accommodate for that, right? Like we can help a baby who doesn't have that skill. But it is important to be aware of that role and how when we have kids like really tightly swaddled to breastfeed, it's inhibiting them, kind of being in an optimized state to demonstrate the skills and use the skills that they have and to develop the skills they need to teach, to learn how to eat well. So keep an eye out. Hearing it here, hopefully it'll help you recognize that role, would see how babies do use that flexion and orienting their arms and legs towards a midline, how they use that to feed well.
And just real quickly on the other side of that, when we're working with them to put their baby to the breast, they're focusing on the baby getting latched onto the breast. And so I have found it helpful to encourage the mom to get comfortable and then make sure she feels stable holding the baby, because she isn't thinking about that. She's only thinking about the baby's mouth and her breast and putting them together, and doesn't realize, kind of what you're alluding to, Claire, that her comfort, some of that will just happen because you are comfortable and the baby can use the skills that they have, and the mom will be able to then hear hers because she won't be worried about connecting.
Yeah, one time I had a kind of out of body experience, remembering myself as a first time mom, new mother, and how breastfeeding looked. And it was me and this like special nursing nightgown that had little slits and a special nursing bra that had a little triangle of like areola and nipple, and the baby was like had a hat, she was all bundled, and like somehow I'm trying to like fit those two things together like they were puzzle pieces on a table. Like it somehow there was no relation of her body to my body at all. So I've realized how much that's what's happening when we don't consider that really the mother is the baby's natural habitat, and we want as much contact between those two things, just like that's what optimizes latch. And we're going to do a whole other webinar on latch and teaching optimal latch. But like the more surface contact there is between the baby's oral cavity and the mother's areolar complex, the better. So more contact, better.
Yeah.
Moving on.
Moving on. Okay, so I think, yes. So I mentioned earlier, we saw pictures of babies who were past "I'm very hungry," and they were, some of the things that were mentioned illustrated that the baby was experiencing stress. And so considering the idea of feeding a baby, then the baby's passive versus helping them to learn to eat. That's the concept leads you to understand that the baby's an active participant. Let's look at some of the signs that a baby might show if they're experiencing stress while eating. They may have a furrowed brow. They may start sneezing or yawning, frowning, grimacing, have a tight mouth, which makes it kind of difficult to get them to latch on. You may notice skin changes in their color. There might be some mottling. They may be, you may observe something that is pretty common, that limb cycling, like they're on a bicycle. They may stiffen up and resist, the movement to try to get them closer to the breast. They may have a finger splaying. They may be saluting. They may have nasal flaring, and some of them may just have gaze aversion. They're not making contact because it's just not working out for them the way it's going. And so watching for these signs can help. We can learn to teach families how to, and guide them how to get the baby comfortable. And what we just spoke about, that physiologic positioning goes a long way in helping.
And that can be applied with bottle feeding as well,
Absolutely.
Right? Like
it absolutely should be, yes.
And these are signs that we see maybe more frequently in bottle feeding, in that if we're really focused on volume, they may be saying, I'm done, or the milk's flowing too fast. NICU nurses know that, like stop sign, right? Like finger splaying or toe splaying, but they can also show it. I remember seeing limb cycling one time and noticing it and not trying to think, is this telling me that the baby's into it? Like they're excited about feeding? No, this kid was like, please, this flow is too fast for me. This was actually a breastfeeding baby, but the mom had been very intent on getting a full milk supply and had really a double milk supply for this cardiac patient. And he was saying the flow was too fast for him. And I didn't really think that through until later. That's what he was trying to communicate with the limb cycling, was that he was stressed. So these are all good signs to change positioning, take a break, end of feeding, and pick it up again. It's okay. You don't have to wait 3 hours. It could be maybe when they are calmed down and we know they haven't eaten very much, that we can offer it again in a few minutes when we've addressed the stress.
So I know we're talking about NICU babies, and so the nurses are recognizing these signs, but it really is, I think, very edifying for parents to start to, along with the theme of watching your baby, and kind of, it will help you connect with the baby, and then again help inform what you need to do next. Do I need to stop feeding? Do I need to take the milk out of the nipple? Do I need to kind of put you in a neutral position, skin to skin? But yeah. So on the other side, We mentioned earlier that we should use infant cues not only to initiate feeding, but also to stop a feeding. And this is particularly important for families who are formula feeding. And so we should be teaching them this information. And here are a quick review of signs of satiety to point out to parents. And I'm going to now hand it back to Claire.
Claire, you're on mute.
Thank you, Kimberly. So to wrap up, we've got kind of some takeaways on the next slide. Hold on, I'm like trying to manage a lot of different windows. But so we'll start with the mother's body, as I mentioned, is the baby's natural habitat. So especially during that immediate postpartum period, it's ideal for mothers and babies to not only be rooming in the same room, but literally like in physical contact, but of course in a safe scenario where if mom's on medication and sleepy, that there's a partner or caregiver, another caregiver helping and a safe place to place the baby. We want to work together to accommodate that need for mothers, baby to be with mother, but also for mother's need for rest. And that can look a lot of different ways. And like we mentioned earlier, if in your facility you do have a nursery or kind of a respite scenario, that we are going to get to a better feeding faster if we're watching for cues and bringing the baby back to mother as soon as possible when they're demonstrating cues. We've kind of want to reinforce what we taught today about frequent feedings, including nighttime feedings being important, like physiologically, both to infants and to lactogenesis, and that those shouldn't be discouraged during the neonatal period. And then also kind of like this, when you think about frequent feedings, sometimes I say, like, how often would you need to eat if you were trying to double your current weight in the next 4 to 6 months? That's a lot of eating. We shouldn't make eating be a negative, like somehow it's better to have fewer feedings. We want to encourage frequent feeding to help babies with that adequate weight recovery and gain. And then lastly, kind of this bigger paradigm shift we're asking you guys to consider today is that infants should be recognized as an active participant in the act of learning to eat rather than just being fed. I know we're kind of out of time for questions, but I'll put my email in the chat, and the committee is always happy to field questions about anything we presented today. Coming up, just a reminder, of course, Mother's Day is this Sunday. I'm sure a lot of you are going to have fun in your unit celebrating that. And we mentioned earlier, World Kangaroo Care Day is this coming up next week. There is a link in the chat further up about that slide that Kimberly posted. May is Neck Awareness Month, and May 17th particularly is Neck Awareness Day. So that's something, necrotizing enterocolitis, of course, is a leading cause of infant mortality, particularly in Georgia. We have a very high rate of necrotizing enterocolitis. And then May 19th is World Milk Donation Day. So if you want to recognize that in your unit as well. Thanks for being here today. Do you have anything else, Kimberly?
A little bit. Thank you, Claire, and thank you, Teresa. That was fantastic information. I just want to do a reminder that the May audit will go out on May 22nd, and then to please join us June 13th for our June webinar, Breastfeeding Exclusivity and Appropriate Supplementation. And just don't leave this before you scan this QR code to log your attendance for this month's webinar. This will also be posted on the GaPQC website with the link there. So if you do need to run, you can always come back to that link. Just make sure that you log that so that we know you were here. And thank you all for attending today. Have a wonderful afternoon.